All right, we'll get back to it. It's been 10 minutes. We're gonna keep powering through. We're gonna start with some cardiopath at the beginning. Then we'll move into gastro. So we'll cover the two big high yield sections today, the two 12%. And if we have time to get into blood, we will. If not, we'll do that next week. So we will make sure we touch on the blood one as well. When we're dealing with pathology for the NPLEX 1, these are the things they expect you to know. This is from the study guide that I posted online. This is the 2022 study guide, but like I said, it's pretty close to 2023. They want you to be able to understand the etiology, the risk factors, the complications, the clinical characteristics, and most importantly, the pathogenesis. So how is it presenting from a cellular or physiologic level? So it does not ask about diagnostics, lab results, treatments, imaging, things like that. Really, it's pathogenesis. Those are cellular changes or things that we need to know. Is there specific etiology, risk factors, complications, or clinical characteristics we need to know? So that's really what we're going to lean into with all of our path discussions. How I would encourage you to review or study these things at this point is really just at the baseline, understand what the disease is, right? From a secondary perspective, if you can get to like what tissues are involved, that as the pathogenesis, that would be great, or what's happening on a tissue level. And then from there, if you can get any of the other kind of clinical characteristics, risk factors, complications, etc., cool. But I at least have name recognition with the condition. They're most of the time going to give you the condition. So the clinical characteristics are really only if there's some fun ones. We'll see that with infective endocarditis. We'll see that with rheumatic fever. There's some like really specific clinical findings that have funky names that are often on the exam. So that's when the clinical findings come into play. Because remember, typically they're going to give you the actual diagnosis of what they're talking about in your case vignette up top. The different conditions I've pulled from are sampling from the actual list. It's never all of them. You're never tested on every single one. I tried to pull the ones that seem to come up time and time again in these path sections. And if you're looking for some high yield stuff to do over the next week and a half for fun, and you like flashcards. If you don't like flashcards, then just zone me out for a minute. But I really enjoy Brainscape's flashcards. You can actually purchase a membership for a month for $10. I know it's a paid thing, but they have flashcards you can download that are from USMLE, step 1, just pretty close to what we study. We just minus the pharmacology piece pretty much. And they're pretty decent, honestly. And why I like the flashcards is they will actually give you like little case vignettes sometimes. So like 18-year-old IV drug user presents with fever, new murmur and lesions on his fever is shown. What is most likely responsible? And then you can reveal the answer and it says like, oh, this is splinter hemorrhages likely associated with Staph aureus. And then the condition we could look into, okay, well, what condition has splinter hemorrhages? Do we know? Infective endocarditis. Absolutely. And so you could say, I knew this perfectly. It won't show up that much, or I have no idea what they're talking about. And then it'll come up more often. It forces you to not study too long if you don't want to. So I find it to be really helpful. I purchased them and downloaded them for fun because I have a plane flight coming up and I was like, oh, I'll just do some flashcards. So they're actually pretty enjoyable. You also can search, if you have a free account, you can make your own flashcards, but you can't really use others. If you do the 1 month paid thing, you can search other people's accounts. And so like if you searched for NPLEX, you'll find NPLEX flashcards from all of us past. So even current residents flashcards, and you can actually like click on them and sample them and start studying their decks. So it's a great way if you're a flashcard person to be able to have access to things that are actually appropriate. Quizlet's good too. I like Brainscape because like the 1 through 5 thing really works for me of like being able to grade how well I know something. So just another option for study if you are finding like it's hard at this point to find practice questions that you haven't already seen. All right. So of the cardiology lectures, am I recording? I am. Okay, good. Of the cardiology lectures, we're going to take a sampling of them. We're not necessarily going to go through all of them. We're going to start with valvular disease. We'll move through myocardial and pericarditis, and then we'll do vascular conditions. And then we'll see if we have time to circle back to hypertension, CHF, and ischemic heart disease. I find that your cardiopulm block, and this is pre me teaching in it, okay? So this is not my biased opinion. This is prior to that, is sufficient for these kind of ischemic cardiovascular conditions and CHF. It's these ones that we don't see as often. So that's why I'm going to lean into those for our study purposes here. So we'll start with valvular conditions. I think that is 1F, valvular disease. Okay. So cardiac path, valvular disease. So this is the part of the study guide that I'm referencing here. So these are the conditions we'll look at: aortic and mitral stenosis or insufficiency, mitral valve prolapse, endocarditis, rheumatic heart disease, and a little bit about carcinoid. Of these, I see MVP, endocarditis, and rheumatic heart disease on there often. So those 3 are often tested about because there's just some really easy grab test questions that we can pull. So remember our murmurs. There won't be too many on here about murmurs because again, you're not going to be able to listen to anything. You're not going to get any images. There's not a ton that they can do. And this isn't a diagnostics test. So they're not going to ask you to diagnose this. But just remember our aortic stenosis is a systolic murmur that could be asked. It's crescendo, decrescendo. Typically it's due to age-related calcification or could be due to a bicuspid aortic valve. Your risk factors would be age and atherosclerosis besides the bicuspid aortic valve. And complications, you're sad. So syncope, angina, or dyspnea on exertion, as well as your left ventricle pressure is less than the aortic pressure during systole. Versus regurg, this is a diastolic murmur. You're going to have BEAR as your etiology: bicuspid aortic valve, endocarditis, aortic root dilation, and rheumatic fever. So endocarditis and rheumatic fever being a part of the etiology for this murmur means this murmur could be brought up on your test because they love to test on endocarditis and rheumatic fever. Complications typically is left congestive heart failure. Mitral stenosis, this is a diastolic murmur dealing with our mitral valve. It typically follows the opening snap. Again, I don't think they're going to ever ask you to describe the murmur, or they're not going to even list probably these clinical characteristics outside of diastolic, systolic, and wanting you to know where the valve is, so what it's separating between. I don't know where there we go. Okay. The big risk factor for this one, or etiology for this one, would be rheumatic fever. And complications: left atrial dilation, pulmonary congestion, AFib being a big one, Ortner syndrome, hemoptysis, or right CHF. I see AFib or right CHF being tested on more. And pathogenesis is really left atrial pressure is greater than ventricular pressure. Heart murmurs, mitral insufficiency, it's a systolic murmur. Really ischemic heart disease post-heart attack. Mitral valve prolapse, rheumatic fever, and infective endocarditis are also on here. Those can cause like all these murmurs, really, right? They can contribute to a lot of them. If they have valve, they often have valve involvement. Mitral valve prolapse, this is the mid-systolic click. So that would be the only one that they might ask you about a sound, right? Which murmur is associated with a mid-systolic click? No mitral valve prolapse. That would be probably the only one I'd expect them to say. Maybe crescendo, decrescendo for aortic stenosis, maybe, but probably not. Those 2 sounds. Mitral valve prolapse could be born at birth with it, but rheumatic fever, chordae tendineae rupture, and myxomatous degeneration, which is a connective tissue disease, are etiologies. Complications typically benign, but could predispose an infective endocarditis. Okay. That was your murmur rundown. All right. So murmurs, what do you need to know? You need to know the valve. You need to know if the murmur is a regurg or a stenotic murmur. So is it hard to open, or is it blowy and allowing blood to flow back and forth? And then when you hear the sound, is it in systole or diastole? That would be my baseline from there. That would really be all I would worry about murmurs at this point in time. Great. All right, endocarditis. So endocarditis, we're going to talk about infective endocarditis first. This is the infection of the endocardial surface of the heart. The endocardial surface, where is that on the heart? Where is that located? Inside the lining of the ventricles, the lining of your valves, right? Versus myocarditis, or the myometrium, is what? The muscle layer, and then the epimysium is the outer layer. That's the connective tissue that kind of is continuous with that fibrous layer on top. So endocarditis is the innermost layer that's involved here. Typically, you're seeing at least one heart valve being involved. It can be more. You also, though, can have non-bacterial thrombotic endocarditis. By far and wide, they're going to test you on infective, okay? But I want you to know that there is a form that is non-infective, because if they ask you, like, can you have a non-infective endocarditis or something like that? I don't know. I don't want you to say no just because you haven't heard of it before. So there is a non-bacterial thrombotic endocarditis. It's very rare. It's typically seen on mitral aortic valves, and it's platelet-rich thrombi that dislodge easily and that are sterile. So if you did a sampling of the thrombi, the vegetations on those valves in the non-bacterial thrombotic endocarditis, no bacteria would grow out of them. Versus a typical infective endocarditis, you'll see, if we sampled this, we'd find some bacteria that grew out. And then, for example, this is strep endocarditis. So some etiologies. Bacteria is much greater than fungi, and I have some bacteria that we want to pay attention to here in a moment. But so bacteria is going to be a big one. For acute infective endocarditis, Staph aureus is going to be one of your biggest etiologies. It's going to cause large destructive vegetations on normal valves and has a rapid onset. For subacute endocarditis, you're going to see strep viridans as being your most common etiology. You'll see smaller vegetations on valves that are congenitally abnormal, or valves that have disease, and this will be more of a gradual onset. This is the endocarditis that we associate with dental procedure risk, is our strep viridans. Now, there are also some other associations depending on valve area. So these were acute or subacute. I would know these first. So when in doubt, learn these two ones. Acute endocarditis, Staph aureus, subacute strep viridans. Both of these bacteria are gram-positive, and both of them are cocci. So that's something that you can remember about both these bacteria. All your staphs and all your streps are all gram-positive, and they're all cocci, circular. Anytime you have a staph or a strep. Yes?
Question that does see the bacteria, they could start here. What would
of why it was strep viridans, or
the bacteria type,
okay,
or endocarditis,
yes,
and then the strep viridans stuff.
Yes.
Is there a way to
differentiate the two? So I would probably look to the case. The question was, if the answer was strep viridans and the case was asking what was the etiology, and it gave a bunch of bacteria and it didn't really give a lot of clinical clues or context, how would we get there? I would look at the case and see if they gave you any timeliness or onset. And if it was shorter than if it was like 2 weeks or less and like a quick onset of symptoms, I would go with Staph aureus. It was a slower onset of symptoms, or if they said insidious onset or anything like that, strep viridans. When in doubt, they're both really good answers. So it would really have to be the timeliness of the two, or if they mentioned anything about dental procedure or congenital valve, that would lead me down strep viridans, versus Staph aureus would be if it's normal valve. So if the person had no prior valve disease and no previous dental work, and they were having an infective endocarditis, and maybe I didn't get a time at all, I would go with Staph aureus if their valves were healthy beforehand. If their valves were not healthy beforehand, I'd probably go with strep viridans. Yeah, and there may be practice questions that don't even differentiate that. And if so, then both are correct. So choose your favorite one. That's what you do. Yeah. And maybe write a snarky letter or snarky note to the test writer. That's what I did. Okay. All right. So risk factors based off of bacteria. So these are the most common two types, most common etiologies. But there are some special scenarios that they could give you where it would be a different bacteria. That's what this next slide is. So if you remember those two already and you want some more, here's your more. So staph epidermidis is associated with a prosthetic valve specifically, so different than Staph aureus. If you did a gut procedure or a GU procedure prior to getting endocarditis, Enterococcus is a gram-negative rod. They tend to live in the gut, and so are being more likely to be exposed from the gut. So that's why if there was a GI or GU procedure that led to infective endocarditis, I'd lean into Enterococcus. Colon cancer is associated with our Staph galacticus or bovis, or is it strep? It's strep bovis, strep galacticus, sorry. I have seen that one asked before, the bovis version. IV drug use, you could see Staph aureus or Pseudomonas or Candida, but again, bacteria is more common than fungi, so I'd lean into Staph aureus or Pseudomonas for IV drug use. And if it was me, I'd choose Staph aureus every time. If it's culture negative, Coxiella or Bartonella, that means if you cultured it and nothing grew out. And gram negative, your gram negative options are your HEK, H-A-C-E-K, so Haemophilus, Actinobacillus, Cardiobacterium, Echinella, or Kingella. Of these, joyful list of bacteria and bugs, I would, if you have Staph aureus and strep viridans committed to memory, I would learn this one, your Staph epidermidis, and your GI/GU, your Enterococcus. This one's easy, IV drug use, Staph aureus, because that's also acute infective endocarditis. So that one you kind of already know. So these two would be the ones I would also memorize if you can. Commit another to memory. Okay. So what are some things that you can see in infective endocarditis? You can see from Jane, so the clinical characteristics, you can see fever, you can see different vascular phenomena like septic embolism, petechia, splinter hemorrhages, and Janeway lesions. Splinter hemorrhages was the hemorrhages that we saw on the nails from that practice question. Janeway lesions, we can see there are these painless flat erythematous lesions on palms or soles, so hands or feet. We often don't have a lot of things on the palms or the soles of our hands and feet. So if there's a lesion there, like that's significant. There's also immunologic phenomena, so immune complex deposition, so like IG and antigen complexes. So that can lead then to glomerulonephritis. Osler's nodes, which are Osler's nodes, we can see in your fingers or toe pads. They're kind of these purple lesions that are raised. They may or may not be tender to touch, but you'll feel them. And then Roth spots. Now, Roth spots are associated in the eye. They're retinal hemorrhagic lesions, and they have this pale center in the middle. I don't know if I have pictures of all of them, so that's why I'm kind of listing out a description for you. But you're not going to be given a picture, right? So if you can memorize from Jane and know these associations, these clinical characteristics, you'll be great. They're probably going to give you the condition, right? So the questions they'll ask then are going to be about the etiology, the bug. So that could be a path or a micro question. And then they could ask about the clinical characteristics. So they could ask you to define or to list out some of the clinical characteristics of infective endocarditis. And they would probably give you some characteristics here. And they'd probably also give you some rheumatic fever characteristics and try to have you get confused between the two. We're going to look at both of them. Different criteria, both have lists. So from Jane is your bacterial endocarditis clinical characteristics: fever, Roth spots, Osler nodes, murmur, Janeway lesions, anemia, nail bed hemorrhages, and emboli. Mitral valve is the most commonly affected, more than aortic. Tricuspid is more associated with IV drug use. Don't try drugs. And endothelial injury is the formation of vegetations essentially consisting of platelets, fibrin, microbes, etc. This like clump of stuff on heart valves. That is your pathogenesis of the endothelial injury in infective endocarditis. Complications: valve regurg, septic embolism, could lead to death. It's not great to have your heart have infections and little like collections of bacteria on your heart valves. So it is a significant condition you want to recognize and treat. Okay. The non-bacterial, typically asymptomatic. Your main complication is an embolism. So it's more associated with hypercoagulable states. So you could see it in cancers, you could see it even in autoimmune conditions. I doubt they'll test you on this outside of wanting you to know that there is one that exists that's not bacterial in nature. Any questions about endocarditis before we move on? Know the bugs and clinical characteristics, right? All right. Rheumatic heart disease. All right, definitions, immune mediated. It's a type 2 hypersensitivity. I know we haven't talked about those. We are going to talk about them on Monday or Tuesday of next week, our next class. So it's a type 2 hypersensitivity. We see antibodies that occur to the M protein. They'll cross-react with self-antigens, which is often myosin. That's cross-reacting. So we see an antibody now attacking or targeting myosin. The etiology is a pharyngeal, typically, infection with group A beta hemolytic strep. And there's not a direct effect of bacteria. It's really these antibody, this immune-mediated component that's really causing the disease. Complications, you can see valve regurg early on and stenosis later. And if we look at the pathogenesis, we'll see where it affects. It's going to affect heart valves in this order, this MAT order, hence the rheumatic heart disease, mitral first, aortic next, tricuspid last, which is pretty similar to endocarditis. We'll see here, if you look cellularly, you can see something called an Aschoff body. This is a granuloma that has giant cells. So this would be a pathognomonic potentially lesion that you could see histologically. So anytime there's a histological something associated with a condition, it's good to remember that association for these tests. You'll also see the Antishikoff cells or Antishikow cells. These are enlarged macrophages and they have a rod-like wavy nucleus. You'll also see increased anti-streptolysin O, increased anti-DNase titers, because your body is essentially having this big immune response. So what does this look like? Rheumatic fever, your clinical characteristics. This is what I really want you to know. Your Jones criteria. So your joint, your migratory polyarthritis, you'll have joint pain that migrates. You'll have carditis of some kind. That's why it's a heart. So inflammation of the heart. You'll have nodules on your skin, subcutaneous nodules. You'll have erythema marginatum, which is this rash that has a ring margin. And then you'll see Sydenham chorea, which is essentially involuntary movements of limbs or face, almost like contractions or tics. So this would be the Jones criteria, different than your previous criteria for infective endocarditis, but there is some crossover, like both have nodules, right? Both can have skin stuff. So this is a different etiology and different criteria. Okay, so what do you need to know? Group A beta hemolytic strep, know the Jones criteria, I think, and know Aschoff bodies. I think that will be the most helpful piece. And then typically it's myosin that it's reacting to, the auto component, type 2 hypersensitivity. The last one in this section is carcinoid heart disease. I just have it on here because it was in the section. This is a cardiac manifestation of a systemic syndrome caused by a carcinoid tumor. You can see in about 50% of people that have carcinoid tumors, okay? Not in 50% of people. It involves the endocardium and the valves of the right side of the heart. You can see plaque-like lesions that are inside the tricuspid and pulmonary valves. These lesions have smooth muscle and collagen fibers. You can see flushing of skin, cramping, nausea, vomiting, diarrhea, and tricuspid insufficiency that can lead to pulmonary valve insufficiency. But the key point here is it's associated with a carcinoid tumor and it's associated with the right side of the heart. So there's not a lot of right side heart only things. So that's why this one is more interesting or significant. Okay. That was part one. Ooh. We're going to move now into, did I close it down? Nope. 1G. So the next one, which is primary myocardial and pericarditis. So we're going to get into the types of cardiomyopathies, essentially. Just checking on my online folks. Okay, great. All right. So our cardiomyopathies, we don't have to be afraid of them. So let's go first, our primary myocardial diseases. So we're dealing now with the myocardium. So we're dealing now with the muscle. We were dealing more with the endocardium before, with that inner lining. So our cardiomyopathies, we have dilated, restrictive, and hypertrophic. And then we're also going to talk about myocarditis. So cardiomyopathies, the three types, dilated is the most common dilation of cardiac chambers or ventricles. So the actual chamber itself is getting bigger. Hypertrophic is the second most common, and it's the enlargement of the cardiac muscle surrounding said ventricles. And restrictive is the least common. It's known as infiltrative, and it's decreased ventricular compliance. So the ventricle is able to actually comply or contract or move less effectively because it's filled up with stuff. Okay. So those are our three main types. So if we look at the dilated cardiomyopathy, it can be idiopathic. It can be related to a mutation of a gene, TTN gene, which essentially encodes for the sarcomeric protein tissue. This is a protein that kind of looks like a spring, and it allows for sarcomeres to kind of move back into its normal, or essentially like move forward and move back into its normal length or normal shape. It prevents them from getting too extended outside of themselves, which makes sense. If this is a dilated cardiomyopathy and the chamber is dilating, we're extending our sarcomeres too much. We're stretching the muscle too much. And so if we had a genetic etiology of tissue not being able to hold our sarcomeres in place appropriately, allowing them to stretch, that can logically make sense. Drugs can affect this or cause this, alcohol, cocaine being some. Infection, Chagas disease, or even Coxsackie-B virus can be commonly associated. Ischemia, there can be systemic causes, and even peripartum cardiomyopathy. So lots of different etiologies. I wouldn't necessarily worry as much about knowing all of them. Know that idiopathic is oftentimes what they end up calling it for the majority of cases. I'd say idiopathic or familial genetic. So if we look here, some of the clinical characteristics, we can see things like congestive heart failure. We can hear an S3. We could have a murmur. You'll look at the heart on echo and it'll be dilated and look like a balloon. I think the most common thing they might ask about is the balloon-like appearance on chest x-ray, because that's probably the most pathognomonic type thing that you could see here. You'll also see this eccentric hypertrophy. So sarcomeres are added in series with one another because they're essentially the heart muscle itself is stretching. And so to accommodate for that stretch, we'll have a sarcomere and then a sarcomere and then a sarcomere and a sarcomere. So in series, not in parallel. Sarcomeres, remember, the contractional units of muscle. That's a sarcomere. We can see systolic dysfunction because if we have a really dilated, stretched, thin muscle, or if you think about it, if you're trying to contract your muscle from a stretch position, is it going to be easier or harder? It's going to be more challenging, okay? Oftentimes, if we try to stretch a muscle and then lift weights from that stretch position, that's actually really great. Like it can really strengthen our muscles, but also can damage our muscles because it's hard to actually be able to flex something if we start in extension. It's easier if we start at neutral, right? So if the heart muscle is already extended and tight and taut and stretched out, or even loosey-goosey and floppy, but if it's already stretched and then we want to contract it, it's going to be much more challenging for the heart. So that's how we get that systolic dysfunction, that CHF component. Seeing if there's anything else I want you to know. I think those are the big ones here. Hypertrophic cardiomyopathy, there is a familial component. It's autosomal dominant, genes that code sarcomeric proteins like myosin binding protein C, as well as myosin binding or myosin beta myosin heavy chain. You also can have a chronic hypertension leading to this, Friedreich's ataxia, essentially anything that's going to cause this heart muscle to thicken, right? Because hypertrophic, the muscle is getting hypertrophic, it's getting enlarged, it's getting thicker. So clinical characteristics, you can see an S4, systolic murmur, mitral regurg. You could also see histologically that your sarcomeres are added in parallel, so parallel to one another instead of in series, because the heart muscle is getting thicker, not getting stretched. You'll see dyspnea and potentially syncope. Complications, you'll see diastolic dysfunction in this one because the heart muscle is able to take in less blood. And so you can see black flow actually into you can see backflow up into the atrium because you're not actually able to put in as much blood into that ventricle because it's a much smaller space. I think I have a picture. Yeah, here you go. Oh, that's restrictive. Where's my picture? There you go. Oh, okay. Well, we're going to pretend restrictive is hypertrophic for a second. And so we'll pretend there's not infiltrates. This is just thicker. Essentially in hypertrophic cardiomyopathy, if so this is normal. In hypertrophic, you're going to see just a bigger muscle. So you're going to see a smaller chamber. So this chamber internally can take much less blood. So you have issues with filling versus in your dilated, you have issues with actually getting blood out. So that's why in dilated, you have a systolic problem versus restrictive, you have a diastolic problem with getting blood in with your hypertrophic. With restrictive, then, so I was with hypertrophic. With restrictive, this is when stuff fills in the actual myocardial layers. This is where you have please help. These are the things that can kind of affect or fill in the space. I would say of these, the most common ones that I would want you to know would be amyloidosis, sarcoidosis, and hemochromatosis. So the A, the S, and the H, your as help at the end. These are probably the most commonly tested etiologies for a restrictive cardiomyopathy. Obviously, depending on the condition, will depend on what the infiltrate is. For all of these, though, an infiltrate is being essentially laid down within this muscle layer, causing it to become restrictive, hence its name, restrictive cardiomyopathy. Clinical characteristics are going to be a low voltage, it's an EKG, not ECK. Complications are going to be diastolic in nature because, again, we are going to have this space be filled. It's going to actually have less space for blood to flow in it. You could potentially also see some systolic dysfunction if the infiltrates are making it so you can contract less effectively. So your contractility will also go down. Those are your three. So please help. So for restrictive or infiltrative cardiomyopathy, no, please help. For hypertrophic, understand that it's autosomal dominant. It's typically familial, and it's a diastolic dysfunction. And for dilated cardiomyopathy, know that it's idiopathic or familial with the protein tissue being affected, and it's a systolic dysfunction. Those would be your high yield pieces for your cardiomyopathies. Okay. Right, great. I was looking for signs of help and I didn't see any yet, so I'll keep going. Your myocarditis is just inflammation of the myocardium. Hence itis and myocard. You'll see global enlargement of the heart, dilation of all chambers. You can have complications of sudden cardiac death, of multiple different arrhythmias, of thrombi, of CHF, and even of dilated cardiomyopathy. Your characteristics can look a lot like a heart attack, dyspnea, chest pain, but you could see fever because, right, inflammation of, or arrhythmias, typically tachyarrhythmias. You're going to notice lymphocytic infiltrate, and you can even have focal necrosis, especially if this has a viral cause. So what are some of the etiologies? Viral-wise, some of them include adenovirus, Coxsackie-B, Parvo B19, HIV, or HHV6. Parasitic, Trypanosoma cruzi or Toxoplasma gondii. That one would be cool to know because it has a fun name. Bacterial, Borrelia burgdorferi, Mycoplasma pneumoniae, Corneobacterium, and diphtheria. What's Mycoplasma pneumoniae? Walking pneumonia, right? We had our test on that. Versus Mycobacterium tuberculinum is TB. Yep, you'll never forget. If they leave off the last words like I did, then it's much harder. But NPLEX does that all the time. Okay. Toxins, obviously carbon monoxide poisoning, black widow venom, rheumatic fever could lead to myocarditis, drugs like cocaine, or even autoimmune. Of all these, I would know walking pneumonia. I would know Borrelia burgdorferi. I would know the viral etiologies if you're able to. Coxsackie-B and parvovirus tend to be tested on more. Those four would be my highest yield of this page. Could you see any of them? Sure. Ask as an etiology, but I'm trying to narrow it down. So these four would be the ones I definitely associate. Yeah.
Does it tend to be viral more than bacterial? So what it more than the other?
Not necessarily. Versus like endocarditis, it tends to be bacterial more than viral. Myocarditis, maybe I'd want to lean into viral more than bacterial, but I'm kind of like pulling straws for that one. Yeah. There's definitely more viral association with myocarditis than endocarditis. So if I was asked a question like viral etiology, myo, endo, or whatever, I would say myo would be more likely to be viral than endocarditis. So I'd lean into that.
Sometimes I see questions where they mix and match bacteria with viruses and say like what is the most likely etiology of this situation?
Yes. Then I would go with like the 4 that I list here. So if they list any of those 4, I would lean into those. And if they don't, then choose your best answer. Choose your best adventure. Yeah. With a lot of these path questions and the etiologies, especially when we get to bugs, if they don't give you any other information, it can be hard sometimes to separate out etiology. Okay, moving from myocarditis, now pericarditis. So our pericardial disease, pericarditis, is this inflammation of the pericardium, the surrounding fibrous structure surrounding the heart. You'll see sharp pain that's worse with breathing in, better with sitting up and leaning forward, like that tripod position. The cool thing you'll hear is a friction rub, which is like leather, like squeaking leather belt, super fun. You can see PR depression or ST segment elevation. Complications, you can have an effusion. For pericarditis, I have seen them kind of like present or give you this is a part of their case and not diagnosing it, like having the patient have something else as a diagnosis and then asking if the patient said that they were feeling better in this position, what is the most likely cause of their symptoms or of their acute symptoms or something like that. So I have seen them use that in association with a question. Your etiology is scar in pericardium. So causes could be surgery, connective tissue disorders, or cardiovascular events. Those are the 2 C's. Remember, an acute MI or Dressler syndrome post-MI can be like a common cause. So if there's any MI case or relationship with MI case, and we're talking about something that happens after, pericarditis is in my brain as an association. Autoimmune can be a potential etiology, radiology, or radiation, renal failure. Idiopathic is the most common cause. Infection with Coxsackie virus B. Again, that Coxsackie B virus likes to inflame and infect parts of the heart, or even a neoplasm. Of these, I would remember cardiovascular events, surgery, idiopathic because it's the most common, and infection because there's really like one thing associated. So that's easy. Inflammation of the heart or the inflammation of the pericardium, you could lead to risk of pericardial effusion where you have that fluid accumulating around the heart. I think that, yeah, that's the main piece. Great. Go team. Is myocarditis considered more severe than endocarditis? It depends on etiology, I would say. Both could lead to death, both can lead to complications. So it would depend on the etiology. Like a myocarditis from carbon monoxide poisoning or black widow venom, that would obviously be more concerning because the treatment would be more challenging. But if they're both caused by bacterial substances in nature, both could be pretty severe. Okay. Oops, how do I get out? There we go. Yep. All right. We'll go through 1 or 2 more. We'll see how much time we get, and then we'll break, and then we'll go into gastro. All right. Vascular conditions. Let me see if I want to start with 1 or 2. I'm going to start with vascular conditions part 2 to make sure we get through it. So this would be 1, is that I or L? I, 1I. So these are going to be some vascular pathologies that could be asked about on an NPLEX. So vascular conditions, so giant cell arteritis or temporal arteritis, peripheral artery disease, varicose veins, vasculitis, pulmonary embolism or DVT, Raynaud's, and thromboangiitis obliterans. I have these because they're less common things that we talk about, right, clinically. And so that's why these are some of the things I'm highlighting, not because you'll see them more common clinically. NPLEX doesn't care. if you see it more commonly. So giant cell arteritis or temporal arteritis is affecting branches of the carotid artery. Okay. Your risk factors is female, gender, over the age of 50, and polymyalgia rheumatica. Clinical characteristics, you can see a unilateral headache, temporal artery tenderness, actual tenderness on the temporal artery, and jaw claudication. Irreversible blindness due to ischemic optic neuropathy would be the most significant complication, irreversible blindness. And then your pathogenesis is you're having a focal granulomatous inflammation associated with that artery, with that actual blood cell space. You'll see things like increased ESR and IL-6 levels that correlate with disease activity. So these would be cytokines and inflammatory markers that would be notable in this condition. So we can see like an immune system. Immunologic. Yeah. Okay. Immune system question. I'm like, that sounded weird. So like ESR, IL-6, that could be an immune system question that they would ask in association with a giant cell arteritis. A vascular question they could ask, right? Temporal artery. What does the temporal artery branch off of? So you can kind of start to figure out, okay, like these are the type of questions they might ask in association with this pathology. Risk, again, female, gender, 50, and polymyalgia rheumatica. I think the most common things they would ask about is stuff associated with temporal artery and stuff associated with these two cytokines or markers of inflammation. Then moving into peripheral arterial disease. So insufficient tissue perfusion is really what we're dealing with here. This could be narrowing or occlusion of the aorta or of the peripheral branches. The narrowing or occlusion is typically due to atherosclerotic plaques. That's your high yield piece here. You could see previous history of myocardial infarctions or strokes, or it could even lead to that. Peripheral artery disease, so narrowed arteries, you'll see that atherosclerosis or atherosclerotic plaque is going to be really your big etiology here because it's going to reduce blood flow. So other risk factors, hypertension, hyperlipidemia, age, obesity, coronary artery disease, all of them, all the above could be potential etiologies. Your complications could be ischemia to limbs, stroke, or heart attack. And you might see coldness, numbness, weakness, decreased pulses. Again, this isn't diagnostic. So this is not a diagnostic exam. These are really just to help you associate stuff with these conditions. I think that's really all you need to know with peripheral artery disease. They might ask questions. They could ask about atherosclerosis, fatty streak, fatty buildup, that like pathophys. They could ask about cholesterol metabolism, right? Or fatty acid oxidation or creation. They could ask questions about vascular flow and association with certain tissues, like you have full occlusion of this artery, what tissue is affected, right? That's how really I could see peripheral arterial disease being questioned for you. Varicose veins. These are your abnormally dilated tortuous veins. Really, the big piece here is these are superficial veins of your lower extremity. These are not the deep veins. That's why it's different than DVT. You'll see increased venous pressure, venous stasis, edema, stasis dermatitis, or ulcerations, right? You're having insufficient blood flow back up to the heart. Female, gender, family history, obesity could all be risk factors, sedentary lifestyle, like we could keep going. Some people just have the genetic predisposition to varicose veins. All right, these are the more fun ones. Vasculitis, wherein the vessels get inflamed. So we have multiple different types of vasculitis. We already talked about one. A large vessel vasculitis that we already discussed is giant cell or temporal arteritis. We also have another large vessel vasculitis. You can see the aorta and large branches to the extremities, head and neck, like the Takayasu arteritis. I haven't seen this one asked about that much, except for its granulomatous in etiology, and it typically is in younger patients versus giant cell is in elderly patients typically, so that'd be a differentiation. Your medium vessels, these are your main visceral arteries and branches, so polyarteritis nodosa and Kawasaki disease. Polyarteritis nodosa, you'll see actually necrotizing, so cell or tissue death inflammation involving most of the time renal arteries, but pulmonary vessels will be spared. So that's something of note. Kawasaki disease, inflammation of the arteries with a mucocutaneous lymph node syndrome, so lymph node swelling, typically seen in children. And your coronary arteries are involved, and you could see aneurysm or thrombosis. So Kawasaki, I would associate with children. I'd associate with swollen lymph nodes, and I would associate with coronary arteries. And then your small vessel vasculitis is your arterioles, your venules, your capillaries, your small stuff, right? That's where we can see Wegener's, Scherg-Strauss, and microscopic. Wegener's is, again, granulomatous inflammation with respiratory tract, as well as cell death or tissue death inflammation, necrotizing vasculitis with the small vessels. Scherg-Strauss is the same, but more associated with asthma or eosinophilia. And then the microscopic is really not many immune deposits and really small vessels. So why do I have this table here? Because if you're asked these questions, most of the time they'll list multiple answers that are on this list. And your job is to differentiate the two based off of these identifying characteristics. So if you're able to identify based off of the actual artery or vein, the vessel that they are talking about, whether it's large, medium, or small, that can help if you know where these are defined. And then from there, if you're able to figure out one other piece about them, right? Either an age of etiology, an association with a condition, an association with a risk factor, that will often be enough to be able to help you differentiate between these different conditions. Hi. Then we get into DVT, deep vein thrombosis. These are our blood clots within our deep veins, oftentimes proximal lower extremity veins like the iliac, femoral, or popliteal. Characteristics are common, but etiology, this is where you get to your Virchow's triad. This can be tested on. So stasis, hypercoagulability, and endothelial damage. So stasis, post-op, long drive, long flight. Hypercoagulability, you have an issue with your coagulation cascading proteins. Maybe you're on OCPs, maybe you're pregnant. All those things can lead to hypercoagulable states. Or endothelial damage. So you have exposed collagen that's going to trigger your clotting cascade. Then you have like these actual, the little clots forming, the starting, and then they break off, and then you have an emboli. So these would be your Virchow's triad, these three kind of components here. You also could remember this etiology as thrombosis, if this helps you remember it further. It kind of goes through very similar things, but just a different mnemonic. So it depends on which one sticks in your brain better. But I've definitely seen Virchow's triad asked about before. Pulmonary embolism, the big thing here would be to remember the types, the fat air thrombus, bacteria, amniotic fluid, tumor, the fat bat of pulmonary embolism. So pulmonary embolism, you're going to have your obstruction of the pulmonary artery or any of its branches. Versus our DVT was down low in that peripheral, typically lower extremity, right? Those deep veins. So pulmonary embolism, we've had the emboli travel, and we're in the pulmonary artery or branches, hence the name. Alveoli are able to be ventilated, but they aren't perfused. So it's a VQ mismatch. So what do I mean by that? The alveoli, you can still breathe in air, but they're not getting blood flow. Because the issue is in the arteries. The actual issue is in the blood supply, not in your ability to actually breathe in oxygen to the alveoli. So they're ventilated, but not perfused. Your clinical characteristics, pretty classic, what you'd expect, and sudden death could happen. Again, thrombosis, similar etiologies here for pulmonary embolism as there were for DVT. Okay. I have not seen them ask you about Wells criteria on this test. So I don't think don't even think about it. That'd be on NPLEX 2. Raynaud's, another important component. They do ask about this decently. The primary type of Raynaud's is idiopathic. Secondary is associated typically with a connective tissue disease or autoimmune. So mixed connective tissue disease, lupus, or Crest syndrome. Essentially, what is happening? You're having decreased blood flow to your skin due to arteriolar, so your smaller vessels, vasospasming. And this is typically in response to either cold, temperatures, or stress. There are other etiologies or other triggers that can happen in people, but these are the common ones that they could ask you about. And you'll see this color change, this ischemia or hypoxia, and then often the reperfusion will be bright red, and it's typically fingers or toes. The last one I wanted to leave us with in this conversation is the thromboangiitis obliterans or Berger's disease. This is a vascular insufficiency condition, and you'll see this segmental thrombosing, acute and chronic inflammation of your medium-sized as well as small arteries. You can see this in like the tibial or radial arteries. The big risk factor is this is your heavy smoker and it's before the age of 35. So your younger person, heavy smoker, can be male or female, but typically seen more in males. That's like your patient picture who has this condition. You'll see essentially the endothelial cells, the lining of the blood vessels get toxic via tobacco or an immune response to the similar agent. And it's pretty significant pain even at rest, and you can see even ulcerations. So I would say the big thing for this one is just to know this association with smoking. It's medium-sized kind of arteries, and it's because the endothelial cells are actually having direct toxicity or an immune response to that endothelial cell. All right, flying through. Let me see if I want. Yeah. Okay, we're gonna do the last one we'll do for cardiac is 1H, and we're gonna start on slide 9. That's vascular conditions, 1H, starting on slide 9. Mainly because I want to talk a little bit about arterial and atherosclerosis, just for the pathophys reminder. So arteriosclerosis is the hardening of the arteries, arterial wall thickening, and loss of elasticity. So loss of response to vasodilation or vasoconstriction, right? It's affecting small arteries and arterioles, hence the name arteriosclerosis. Hyaline is really where we see the thickening of the vessel walls. It's secondary to proteins that leak into the endothelium and that are essential. And it happens in hypertension, essential hypertension and diabetes. Or you can have hyperplastic. This is like onion skinning with severe hypertension with proliferation of smooth muscle cells. Hyaline is probably the most common type of arteriosclerosis because it happens with both diabetes and hypertension, this thickening of the vessel wall due to plasma proteins. Hyperplastic, though, once you progress to severe hypertension, you can see kind of this smooth muscle cell proliferation, so it almost looks like an onion. So as arteriosclerosis, again, kicker here, they'll ask you a question and they'll give you arterio and athero. And so the big piece to remember is arteriosclerosis is hardening because either of arterial wall getting thicker or because it's losing elasticity, losing its ability to respond. Has nothing to do with plaques, right? We didn't talk about a plaque at all in this condition. Can you have both? Yes, often you do, right? You'll see arteriosclerosis, hardening, decreased compliance, and plaque formation, atherosclerosis. But they are technically two pathogenesis that are different. Atherosclerosis is very common. You're dealing with your elastic arteries, your large and medium-sized muscular arteries, and it is a form of arteriosclerosis, meaning that if you have a plaque present, you are going to naturally have hardening of the arteries, right? But is all arteriosclerosis atherosclerosis? No. Some arteriosclerosis is not atherosclerotic in nature. So I want you to separate the two of them in your brain. So atherosclerosis, a buildup of our cholesterol plaques in the tunica intima. We'll see the location, a copycat named Willis. So for the most common places for this buildup to occur, plaque formation to occur, your abdominal aorta is your A, coronary arteries is your C, popliteal artery is your P, carotid artery is your other C, and circle of Willis is your named Willis, right? Copycat named Willis. The A, the C, the P, the C, and the W are your components of the mnemonic. So it's inflammation, right? Endothelial cells that line the walls of blood vessels, it's the dysfunction. We'll see macrophage and LDL accumulation. So macrophages are there because they're trying to muck up all the extra cholesterol, this fatty streak the lipids and fats and fatty acids that are left behind because there's just too many and they're sticky and they stick to the blood cell walls. LDL accumulation because likely there's some hyperlipidemia and there's excess flowing through your blood, and that's going to stick on to that fatty streak along the side, and that starts that buildup process. And that's when we call foam cells. Foam cells are these fat cell buildup that we start to see. Macrophages like to eat the foam cells, so they're trying to digest them. So we see both of these occurring in greater and greater greater and greater amounts. Once foam cells form, we could say we get a fatty streak. So this initial process is happening. Once we see foam cells, we will see fatty streaks. Once we see fatty streaks, we'll start to see smooth muscle cell migration to accommodate for these streaks of fat that we're starting to get into the actual tunica intima, that lining. From there, we'll see proliferation as well as extracellular membrane deposition, because the body's trying to kind of figure out how to like take the stuff off and repair as much as it can, because it recognizes there's damage to that wall. From there, the repair process is lying down fibers, right? We talked about that before. If tissue gets damaged, we lie down fibers. It's kind of like the bridge before we ideally remodel. And so we lie down these fibers, and eventually a fibrous plaque forms because we're lying down fibers upon fibers upon fibers. That fibrous plaque is when we then have a complex atheroma. So once we have actually lied down fibers on top of the cholesterol and fat present, that's when this really starts to become more complex. After that, we can see calcification and hardening. Okay, this is kind of that process. Clinical characteristics, you could find nothing. Asymptomatic is the most common answer. Angina or claudication could be appropriate as well. Risk factors, all of your classics. An interesting one, postmenopausal status, keep that in mind. And complication, your heart attack or your coronary artery disease, or even stroke. The familial hypercholesterolemia, this is obviously your genetically associated version. In this, you see pathogenesis where there's loss of feedback control, so increased cholesterol levels circulating. And so you can see this process starting earlier on, and therefore an increased risk. I would not worry about all of the proteins associations with this. I would just recognize it's earlier onset and it's genetic in nature. Awesome. I saw a question. Correct. Macrophages are helping relieve the foam cells, and they're releasing pro-atherosclerotic cytokines at the same time because they're releasing pro-inflammatory markers. That's what they do when they digest anything, is they're going to present it, and then they're going to also release more cytokines to have more macrophages come and more immune system cells come to the area, because they don't know if we're being attacked by a foreign invader or what's happening. They just know that there's something abnormal on the vessel. And so they are doing their job as digesting and alerting the immune system. And their alert is cytokines that are pro-inflammatory and pro-atherosclerotic. Correct. Good question. Okay. Before we go to break and then go into gastro, any other cardiopath questions that you have on your brain that you're like, oh, I need to know? Great. I would lean into the ones we reviewed today as higher yield because they're less commonly discussed. Really know your endocarditis and rheumatic fever because they're always tested on. And then from there, I would say move on, right? Your path that you get at NUNM, if you've had a block class, you've probably gotten more path than you need for this test. It's just helping yourself not be pulled into diagnostics. That's your kicker, is do not be tempted because they do not expect that on this test. All right, we'll do our last break. We'll come back right at 11, so a little bit of a shorter break so we can get right into gastro, and then we'll wrap up the last hour talking about gastropath.